All right, and I'm going to share my screen with you. Trying to figure out which one I want to grab. So we got 7, 8, 9, and 10 today. We'll start with 7, obviously. Downsize you guys so you're not all staring at me while I talk. Put you there. All right. Chapter 7 is airway. So as we go through airway, we're going to talk about the anatomy and physiology. We talked about it a little bit already. Opening the airways, we'll talk about the jaw thrust, head tilt, chin lift. Oral pharyngeal airway, this is the oral airway. There's also a nasal airway that we put in people as well. Our patient assessment for breathing, our patient care for breathing, and then how we're ventilating patients, and foreign body airway obstructions, which that is also part of that AHA BLS provider AHA CPR card that you guys have. So we'll talk about that a little bit again. So this is one of the most important skills that we can use. Airway is super important, obviously, right? Because we need an airway to stay alive. So we have to be able to assess whether or not the patient is breathing adequately and correct the problems if we find one with that. So in order to determine if the patient's breathing is adequate, we look at 2 aspects of their breathing. So the first one is, are they breathing deeply enough? Are they getting that good chest rise and fall in and out? And are they breathing at an adequate rate? So the adult rate for breathing is 12 to 20. So we want to make sure that they're kind of in that ballpark. Their lips aren't blue. They're getting that good quality air in, good quality air out. So with both the adequate depth and the adequate rate, we're doing good. And without that, we're not doing so good. Patients can die from that. So a little bit of anatomy and physiology, revisiting this. So we have this is our upper airway. So our upper airway is really anything from the larynx or the voice box kind of up into our face area. And then we have our lower airway, which is our trachea going down into our lungs. So this is a picture of the upper airway. We have our nasal cavity up here. So that's our nose. We have our pharynx, which consists of 3 parts. Our nasopharynx, so this is our nose area, which is why they call it a nasopharyngeal airway. So our nasopharynx, which is our hard palate, the top of our roof of the mouth, soft palate, and our tonsils are all part of that. We have our oral pharynx, which is why they call it an oral pharyngeal airway or oral airway, because that's our mouth. This is where our tongue is, the vallecula, our mandible, all of that is part of our oral airway. And then we have our laryngopharynx. So this is going to start at the hyoid bone and our epiglottis right in here. And it's going to work our way down through our trachea. There's the cricoid cartilage or the Adam's apple right in here. The trachea, that's your windpipe right in here. You have your thyroid gland at the bottom of that going into your esophagus. And then your vocal cords are kind of in the middle right here, also called your voice box, vocal cords, or your larynx. So that's all considered upper airway. So inhalation, so this is when we breathe in. We take that nice big deep breath in. It's called inspiration. Our intercostal muscles, those are the ones between our rib cages, and our diaphragm, that muscle that's in our abdominal area, that's the one that separates our chest cavity from our abdominal area. That causes a negative pressure when that diaphragm contracts and our muscles, all that contracts. It causes that negative pressure to move inside, bring the air inside of our lungs. When we expire or exhale, push that breath out, those intercostal muscles and that diaphragm is going to relax, and that's going to come into a resting position. That's going to cause the pressure in our lungs to rise and in the air to be forced out of our lungs. So we inhale and we exhale. For pulmonary ventilation, this is the process of moving air into and out of our body. So just the process of us breathing. Oxygenation, this is the levels of oxygen in the blood that will be carried to the body. So this is how we're going to use like a pulse ox for this. So we're going to get there when we do vital signs, but we use a pulse oximeter for getting our oxygen level reading in a percentage up to 100. Respiration, that's the process of using oxygen throughout the body and transporting that gas waste product like carbon dioxide to the lungs to be exhaled out. So we have this whole process of blood going around and around and oxygen coming in, and the blood is moving that oxygen, and it's taking that exchange in a couple places, like our alveoli and our capillaries. And this is all part of this respiration process. So respiration occurs in those two places. It occurs in the lungs and it occurs in the cells. We need both of those to sustain life. So this part right here, as air travels into our body through our mouth and through our nose, air then travels through our pharynx, our oral and nasal, so our nose and our mouth area, into our larynx, which is where the vocal cords are. So it starts up here. We breathe it in, it works its way down into here, continues to go through our trachea and into the right and left bronchi. So this is our trachea right here. This is our right bronchi and our left bronchi. And from there, it travels into smaller air passages called bronchioles. So as these the bronchi get smaller, they're called bronchioles, which is right here. At the end of these little bronchioles, very far distal or furthest end of these are alveoli. And this is where that oxygen exchange is going to take place. That exchange of gases between our lungs and the blood. So we're trying to get that to take place there, and we can have breathing problems because there's stuff wrong with the alveoli. And we'll talk about what some of those are when we talk about the respiratory chapter. Adults and children, a little bit of a difference between them. Children do have a smaller mouth and nose. The tongue is a larger in proportion than the adult because we kind of grow into our tongues. Airway structures are easily more obstructed. And they're just not as developed as we are. So their trachea is narrower. The cricoid cartilage in our neck is less rigid and less developed, so things get stuck in there more often. And it becomes easily more obstructed. So you can see the tongue. This would be the tongue right in here on the adult. It's about the same size as it is on a child. So it just becomes more obstructed easily. So breathing problems. So just understanding some of the anatomy and physiology of adult and child airways helps us identify some reasons that patients could die from an airway problem. So if the patient's not breathing, air is not entering the body at all. The chest muscles and diaphragm, they're not contracting. If the airway is obstructed by a large foreign body or substance like vomit, air can't get into our lungs, so it can be obstructed. If breathing's too shallow, the patient's not breathing enough oxygen to support the need of the body because that exchange isn't taking place, getting the oxygen out where it needs to go and the carbon dioxide back and pushed out. So breathing is occurring with minimal, and we can correct that. That would be like if somebody has anaphylactic shock or if they have a broken rib, something like that. If breathing is too fast or too slow, this is going to require oxygen if not being delivered to the body. So breathing is too fast, and if they're breathing too fast, a lot of times it's also shallow or labored because they're breathing, but they're not breathing in enough oxygen to get that oxygen around to all the cells that it needs to get to. So the rates, and I know these were on the sheet that I gave you for lifespan development chapter, but normal respiratory rates are based on age of the patient. Typically, we have adult, child, and infant, kind of breaking those down. Adult respiratory rate is 12 to 20 breaths per minute. So as we take a breath in and out, that's one breath. How many times do people do that a minute? And we'll kind of, when we get to vital signs, we'll show you guys how to do that. For children, normal respiratory rates 15 to 30. When we're born, we breathe really fast and then we slow down as we age. So as an infant, our breathing rate's 30 to 60. So infant is anything under 12 months. So and again, these are just guidelines that can assist you in determining if the rate your patient is breathing is adequate. So if you have an adult patient that say they're breathing at a rate of 24, are we going to start freaking out? No, we're going to look at how the patient looks, look at some of the other numbers, what's going on with that patient. It's not this ballpark of like, it needs to be between 12 and 20, right? It can be somewhere in that range. It can be a little bit higher, a little bit lower, but it gives us a ballpark. When the body is in need of a little bit more oxygen, like an asthma attack, if somebody's having one of those, the body responds by increasing the respiratory rate to draw in more oxygen into the body. This is why a lot of people are on home oxygen, especially the older folks you guys will be dealing with. The condition of low oxygen levels in the body, we call this hypoxia or lack of oxygen, low oxygen levels. So when we get that pulse ox on somebody, their reading is going to be like 90% or 92% or 88%, where it should be 94 and above. Assessing the airway and breathing. So when we're assessing this, we want to consider some things. So determining if the airway is patent, which just means open. If they have an open patent airway, that's good, right? If the patient is alert, they're orientated, their airway is usually open. If they're talking to you, it's usually an open airway. A patient with an altered mental status may begin to lose their ability to maintain a patent airway. So if they have, like, they start getting kind of going unresponsive on us, they're not sure what's going on, they could potentially lose that if they're having a stroke or a cardiac event, something like that. We're going to observe the patient and look for signs of hypoxia, so lack of oxygen, the presence of cyanosis or grayish bluish appearance. Normal skin color is usually pink, warm, and dry. On darker skinned patients, they're going to take on like an ashen appearance if they're hypoxic. They'll look a little bit pale. We can also look at mucous membranes of the mouth, the lips, to determine the presence of cyanosis. It usually starts around the mouth and the nail beds. So if they have like that bluish, grayish color appearance, they're starting to lose oxygen, and we need to get oxygen on them. We're going to place the patient supine, so flat on their back on a flat surface if they don't appear to be able to maintain their airway. If the patient has an altered mental status, but they're breathing, a lot of times we can put them in that recovery position on their side, left or right. Most of the time it doesn't matter unless we're talking about pregnancy, which would be left. Recovery position is going to allow any fluid. So if they vomit or anything like that, they allow fluid to drain from their airway. When assessing breathing adequacy, we have to consider the rate and the depth of their breathing. So what's that breathing rate? The 12 to 20, 15 to 30, 30 to 60, whatever patient age you're dealing with. And the depth. Are they getting that good chest rise and that good chest fall? Or are they just getting in a little bit? They're not getting that good expansion of their rib cage going up and down. If they're able to speak, we can observe their ability to speak in complete sentences without difficulty. If they can speak one or two words at a time and they're trying to catch their breath, obviously they're having difficulty breathing, and we do consider that significant distress in people. But if they're talking full sentences and they're alert, they're orientated, their airway is usually patent or open. But just looking at their appearance, reading some of their numbers when we get to vital signs, you guys will kind of learn how to do some of that stuff. Just how are they looking overall? So some signs of respiratory distress in people, we have noisy breathing. So if we're hearing any wheezing, which would usually be like asthma, gurgling, which is usually fluid in the mouth or liquid like vomit or blood, or high-pitched sounds while breathing, which usually means they're choking on something in the upper airway. Accessory muscle use, this is muscles of the neck and the chest contracting more than normal. So if you see that they're using their neck muscles or they're straining or they're between their rib cages or straining when they're breathing, that's accessory muscle use. Anxiety or restlessness, is the patient anxious? They're unable to sit still, because when you can't breathe, a lot of people get anxious with that. Poor skin condition, do we see cyanosis? Again, that bluish grayish color. Are they sweating? Are they cool to the touch? Usually people are warm, pink, and dry. So if they're other than that, they're having some difficulty breathing or something's going on. Presence of trauma is another one. Chest trauma present. So do they have maybe like a broken rib? We can look for what's called paradoxical chest movement that indicates a flail segment. This occurs when a segment of the rib cage comes detached. So two or more ribs are broken in two or more spots. And it kind of does the opposite of what, when they're breathing, that goes in, when they're not, it goes out. That's the paradoxical chest movement. So just looking at the chest, is there anything on the chest that is going to, and this includes the back of the chest, right? So this includes your posterior backside of your chest, rib cage. So a lot of people will fall, flat on their back, or they hit something on the way down and maybe have a cracked rib and they're not sure and they didn't see it in the mirror. So is there any kind of presence of chest trauma at all, like either front, on the sides, or in the back, that could be affecting their breathing as well? So we can use our senses to evaluate the airway as well. Observe the scene, look for vomit on and around the patient, look in the patient's mouth for vomit, any blood, secretions, teeth, foreign objects. We can listen for abnormal breath sounds. A lot of times gurgling, snoring. So gurgling is going to be the presence of fluid in the patient's airway, while that snoring is going to indicate it's partially obstructed. A lot of times this is if somebody's laying on their back, supine position, and maybe they go unresponsive, you start hearing snoring. Well, our muscle's a tongue, so our muscle is going to fall in the back of our throat, and that's going to cause that snoring. That's the biggest problem with that. So the next step we have with this is opening airways, which would be taking care of that. So if you hear gurgling, we probably want to get the suction out. If we hear snoring, we probably want to open their airway up. We can also look for signs of hypoxia, like pale or cyanotic skin, mucous membrane, sweating, cool skin, that type of thing. So that's just assessing for these airway and breathing problems. If we see a breathing problem, there's some things we can do. We can open the airway. There's two ways to do this. We have what's called the head tilt chin lift maneuver. So we're going to use this maneuver to open the airway of an unresponsive patient who has no suspected spine injury. If they're sitting in their chair, they're laying on the floor, and they didn't fall and hit their head and don't have a head, neck, spinal injury, we can use this maneuver. We're going to position ourselves at the patient's head, place one hand on their forehead and the other hand on the tip of their jaw, where that little bony part is right here, not on the fleshy part. And we're going to move the jaw upwards and move the patient's head backwards. This is going to move the neck, which is why we don't do this maneuver if somebody has a C-spine or like a neck injury. We're going to manually hold this open until we get an airway put in there. The other option, if you know somebody fell, hit their head, maybe they have a neck injury, is what's called the jaw thrust maneuver. So if they have a spine injury, doing the head tilt chin lift can cause damage, so we need to avoid it. So doing this is positioning your fingers so I always put my thumbs on that occipital bone, which is right kind of at the lower part of your eye. There's a really hard bone right there. So I'll put my thumb there, and you're going to grab, this is that angle of the jaw. You're going to grab the angle of the jaw, and you're going to pull the jaw forward. So as you pull the jaw forward, you're going to push down with your thumbs and pull up right here, and that whole mandible is going to pop up, and it's going to open the airway out. It's a little bit more difficult than the head tilt chin lift maneuver, but it's frequently used as a way to open the airway. So spinal injury versus no spinal injury. We have the head tilt chin lift for non-spinal injury, and we have the jaw thrust maneuver for spinal injury patients. So that's opening an airway. So once we have an airway open, we need to see if we need to suction. So after opening the airway, we're going to examine for blood, saliva, vomit, teeth, foreign objects, anything that might be in there. A lot of times these older folks will have partial dentures, that type of thing will come out. Any material or substance has to be removed quickly and efficiently. Two basic types of suction units. We have manually powered and electric powered. Manually powered are the ones that are like the handheld ones, typically in like first responder bags. And then electric powered ones are usually some battery source, like the one that's right here, or the one that's on the ambulance. They flip the switch and they pull on the power. So you guys will most likely, if you have bags, usually the EMR level, we're doing the manually powered ones. Suction catheters, these are devices used to clear the airway when attached to the suction unit. So the rigid catheters, these are made of plastic. This is called a Yonker tube, what he has in his hand right here. This Yonker tube typically has a hole in the end of it that you cover, and you'll put it in the patient's mouth and then uncover the hole because we suction on the way out. It goes through this tubing and it collects into this container. Sometimes people carry the flexible or soft catheters as well. Those are usually more small bore. They clog kind of quickly. A lot of times you'll want to have some saline with this so you can clear out your suction unit if you're using some of these powered ones. But anytime the airway has a presence of a substance that's in it, we need to clear the airway out, depending on what kind of suction unit you have. The technique for doing this, take standard precautions. So gloves, probably a face shield and a mask because stuff happens when you're out there suctioning, stuff flies around. Assemble the suction catheter if you need to. We're going to open the patient's mouth. We're going to insert the catheter into the patient's mouth without applying suction. Once the suction catheter is in, we're going to apply suction and begin to withdraw the catheter while we maintain suction. We're going to move the catheter side to side or in a twisting motion around their mouth so we can suction all sides of it, try to get all that out of there. And we're going to try to limit our suction time to the minimum necessary to get the airway cleared. If this is somebody that we try to limit stuff to 10 seconds or less, but you need to suction until the airway is clear. So just use the minimum amount of time you need to do that, get the airway clear, and then you're going to go and reopen the airway again. And then after we do that, we need to maintain the airway being open. So we don't have to sit there and hold it the whole time. So we can open the airway. We're going to look in there. Does it need to be suctioned? No. Great. If it does, we get the suction out. We suction. We reopen the airway. And then we can use what's called an oral airway. So this is an oral airway, this little guy right here. So again, standard precautions, eye and face shield protection. We're going to measure anything we put in people, we need to measure. Suction, you are going to be putting that in their mouth. You can measure that. I suggest to my students that you're not just jamming this in people's mouths, right? You're watching where the tip is. You're not putting it down their throat. So as long as you can see the tip of it, you're fine. But when it comes to airways, you're not going to be able to do that. So anytime we put an airway in somebody, we're going to measure. So we're going to measure from the corner of the mouth to the jawline right here. These come in different sizes, from infant all the way up to the big ones. So we need to measure to make sure that this isn't hanging too far down or too far up. So this, what is going to happen eventually is we're going to put this in. This is going to go behind the tongue, push the tongue forward, and it's going to create an airway for us. So we're going to measure this from the side of the lips down to where that jawbone comes up. We're going to put it in upside down. We're going to put it in about halfway, and we're going to rotate it 360 or 180. Then we're going to drop it in the rest of the way. And then it should look like this when we're done. This whole thing is going to come down. It's going to be coming down into here. The tongue's pushed forward. It's going to create that airway for us. The other thing people do carry also is a nasal or a nasal pharyngeal airway. And that is going to go in our nose area. We're going to measure that from the nose to the tip of the earlobe. And we're going to stick that down the right nostril. And there's some indications, contraindications for these. So indications of how we would use these. If that person is unresponsive, we would use them. Otherwise, they'll have a gag reflex and start vomiting on you. Nasal cannula or nasal airways. We can use those if people have like a clenched jaw, something like that. We want to go with oral first, and then nasal is our second option. If they have like a broken nose, we can't use them, stuff like that. So oral airway is kind of the way to go if we can get an oral airway in somebody. All right. Patient assessment, breathing, some examples. So asking stuff like, are the following patients breathing adequately? So patient is sitting in a chair, complaining of chest pain, they're alert, they're able to speak in complete sentences without difficulty. I would think that that person probably has an adequate airway. You respond to a call where you find the patient on the ground, they're unresponsive, breathing is slow and shallow. You note gurgling sounds, and the patient's very pale. So that one, probably not breathing very adequately, right? Because we have slow, we have shallow, we have gurgling sounds, which means there's probably fluid in their airway. So probably have to get the suction out after we open the airway. Patient fell downstairs, they're holding their badly broken leg and screaming in pain, breathing is rapid and deep. They're probably breathing adequately in that it's appropriate for that situation. Patient is thrown from a car during a rollover. The color is poor. They're not moving or talking. There's no chest rise. No air appears to be moving in or out of their nose or their mouth. That person is not breathing at all, right? So we're going to have to start rescue breathing on that one. Some factors to consider with these. So assessing the breathing status of a patient should include the rate and depth of the breathing. So again, rate our numbers, right? Adult 12 to 20. What's that rate? What's the depth? Are they getting that good chest rise and that good fall? Are we hearing any abnormal sounds? Striders, like high-pitched, like barking, wheezing, gurgling, again with fluids, snoring, that kind of thing. Now, a lot of times you can hear that stuff without a stethoscope even. Just, are you hearing any abnormal sounds? What's the patient's mental status? A decrease in mental status is most often caused by hypoxia or lack of oxygen. So trying to get a lot of this stuff we're doing quickly so we can get oxygen on people. Increase or decrease pulse and respiratory rate. So as the body becomes hypoxic, the body loses oxygen. The breathing and pulse rate increase in order to get that needed oxygen to the body because blood is pumping around all this blood, right? So as hypoxia persists, the pulse rate is going to start to fall, and that's kind of an ominous sign. So if they have a fast heart rate and a fast breathing rate, they're probably in some type of hypoxic crisis. So movement of the chest, that should be adequate enough to deliver good depth of breath. If they have like a cracked rib or something like that, they might not have that good movement of the chest in and out. And the effort or work of their breathing. Those are those signs of increased effort or work of their breathing, using those accessory muscles in their neck and in their chest, the retractions, kind of like a sucking in between the ribs, above the clavicles and your sternum area. Are they using that area to breathe? They shouldn't be normally. So that would be the effort or work of their breathing. All right, emergency care for breathing. So we'll talk about some different types of oxygen masks, oxygen tanks, and that type of thing. So let's start with this one. This is a pulse oximeter. So the air that we breathe contains about 21% oxygen. Oxygen that we breathe in is transported on our hemoglobin in the blood, and the amount of oxygen on the hemoglobin is called our saturation. This is why it's called like a pulse ox or a pulse sat. The pulse oximeter measures the oxygen saturation of the hemoglobin and gives us a reading as a percent up to 100%. When it's applied to a patient's finger, like in the picture, a probe assesses the saturation by sending infrared light through the finger to the sensor on the opposite side. So under normal conditions, a person should have a reading of about 96% or above. That's kind of been moved down to 94 recently. We don't really put people on oxygen until they're 94 or above. A reading level between 90 and 95 is starting to indicate hypoxia, and a reading of less than 90 indicates severe hypoxia. It's a tool. We're also going to treat how the patient's looking. We're not just going to use the readings from the machine because you could have a low battery or things could be not getting a good reading, something like that. But it's a tool that we can use, but we always want to treat our patient. So some pulse oximeters can't tell whether hemoglobin is saturated with oxygen or carbon dioxide or carbon monoxide. So they could have carbon monoxide poisoning and read 100% when they're really not getting oxygen. It knows it's binding with something, it just doesn't know what. So again, treating our patients, not just the numbers on the machines and tools that we're using. Oxygen tanks, you'll see these in the houses probably where you guys are going. Oxygen is carried in cylinders. Most cylinders are made of aluminum. Some part of them should be green, indicating that they contain or place them. We're not going to put them by a heat source, but if they have green on them, they're typically oxygen. We're not going to use oil or grease on these. They contain a compressed gas, so we're going to store and carry them with care. We're not going to drop them. It can result in a fire too. So we shouldn't be having people smoke near them. And we've all seen, the people that are sitting at the casino smoking their cigarette with their nasal cannula going. I would suggest at this point in your life not to sit next to those people because things happen. The cylinders come in various sizes and are identified by letters. As the letter moves through the alphabet, so does the size of the cylinder. A D cylinder contains 350 liters, so that would be the smaller one on the bottom of the screen. And an E cylinder contains 625 liters. That would be the top one. It's just longer. They get bigger and longer and smaller. They have a bunch of different sizes people have. A cylinder has a stem at the top of it, which is this area right here, where this regulator attaches to that. They're used to allow the compressed gas to leave the cylinder in a controlled measure. So we use this regulator to control the oxygen coming out of this tank in a controlled fashion and measured fashion. So these regulators provide a gauge that allow us to have oxygen leave the cylinders in what's called liters per minute or LPM. So this is where we can set different levels of things that we'll talk about coming up here, like our nasal cannulas are set at something, our non-rebreathers are set at 10 to 15, our bag valve masks are set at 15. It's all liters per minute. So oxygen delivery to patients, we have our oxygen cylinder here. We have our stem. There's a valve up here that we have to turn on. This is our regulator that attaches. And then our flow rate right here of liters per minute starts at 0, and we just roll this until we get to the one we want. And this is the PSI that's in our tank. Tanks at full PSI are usually 2000 PSI. That's just pounds per square inch. So as we use these, it goes down, usually around 500, or this red line is where we change them out. So regulators have a 3-pin system. To place the regulator on a cylinder, we're going to line these 3 pins with these 3 holes right here. So these 2 pins right here are going to go into the bottom. And this middle pin right here is where the oxygen comes out, and that's going to go right into here. When we put it on, we can just hand tighten it. Don't crank on it too much, just hand tighten it in place. The cylinder at the top of the valve has a stem that opens the flow up here. We're not going to open the valve unless the regulator is attached. Once the regulator is attached, now we can open the valve. If you hear a hissing sound, something like that, turn it off. It's not seated correctly, or there might be a crack in the O-ring. So turn that off. Look at there's usually like an O-ring right in here. It can be plastic, can be rubber. Sometimes that's cracked or old. So we have to replace that. We can apply a small O-ring over the large pin if we need to. Sometimes they're changed, sometimes they're usually good for a few turns. And again, full cylinders, 2000 PSI, and we replace them when they reach 500. So this is the 3-pin system. You're going to put this in to here. You're going to screw it in with this right here, and then we can turn it on. And as we turn it on, we're listening for sounds. If we hear something, we turn it off and reseat it, etc. Delivery to patients for oxygen. There's oxygen supply tubing. This is used as like an extension for things. We don't use it a ton, but there is supply tubing that we can use for, say, if we have a pocket mask. A lot of the pocket masks now will have a little port on the bottom of them. We can hook the oxygen to. We'll talk about some non-rebreather stuff coming up, masks, nasal cannulas, some of that stuff. So non-rebreather mask, which is not this. Actually, non-rebreather mask is this one with the bag on it. This is called a venturi mask. So a non-rebreather mask that delivers 90% of oxygen when placed on the patient. This is set at 10 to 15 liters per minute. If the reservoir in the mask is deflating during the patient's breathing, we want to use that higher rate of 15. A lot of times when we put something on a patient like a non-rebreather mask, a venturi mask, a bag valve mask, we're setting it at higher rates than we would with like a nasal cannula with air pushing up their nose. We want to ensure that oxygen is flowing at all times. If the oxygen is shut off while a non-rebreather mask is on the patient, they could suffocate. There are holes in the side of it for people to breathe out. But anytime we have something on our patient, we want oxygen running to it. Venturi masks, like the one in this picture right here, are used to deliver lower concentrations of oxygen to the patient. These are patients with chronic lung conditions like COPD. We don't want maybe that much pressure on them. We don't want that much percent to them. We can adjust this mask a little bit more. This one is usually set at 6 to 8 liters per minute. And it delivers about 30% of oxygen to the patients instead of 90 like the non-rebreather does. This would be the non-rebreather mask right here. They're attaching it to oxygen, and we're going to set this rate right here at 10, 12, or 15, somewhere in that ballpark. So when we're applying these to patients, we want to explain the patient that we're going to be applying oxygen through a mask. Some people get claustrophobic. We're going to turn on our cylinder, make sure that there is oxygen running to our mask first. And then we're going to place the mask on our patient. And then there's this little green cord that comes around them. You can tighten the mask on them. There's a little metal nose clamp that you can pinch gently and get a good fit for your patient. If you don't need that much oxygen delivered to your patient, we can use a nasal cannula. This is a lower oxygen concentration if it's warranted. So like chronic lung diseases, a lot of times people wear these at home. So if the patient is too anxious to tolerate a mask, again, we can use one of these. This is just the one that goes in the nose. So explaining to our patients that, again, we're going to be placing a device on them. We're going to turn on the oxygen. We're going to attach the tubing to the regulator. These are going to be set at 2 to 4 liters per minute. So 2 to 4. So the non-rebreather is 10 to 15. The venturi masks, which at our level, I've never, or above, I've never really, we don't carry those in an ambulance. We don't carry those in our first responder bags, but people at their houses might have them. Those are set again with the cord coming off of them. Those are set at 6 to 8. And then these, just think of oxygen blowing up your nose, right? You don't want to set that at 15 because you're gonna be like, it's gonna dry everything out. So this is typically set at 2 to 4. We can go up to 6 with it. Just placing one prong in each nostril. We're going to wrap the tubing around their ears and then tighten it up right here. Just watch their skin when you tighten it up. You don't want to pinch their skin in there. So this is placing a nasal cannula on our patients. So we stick that up the nose, and there are, if you look at a nasal cannula, you'll see where the prongs go in. They'll go in and down, not up. So they're kind of a one-way kind of use. And then you wrap it around their ear and tighten it up. And then make sure you're tightening this, getting a good fit for your patient. That's the non-rebreather mask. Okay, ventilating patients. So we ventilate patients. We can use a couple different things. So we have pocket masks. So these are a device that fits over the patient's mouth and nose. It has a ventilation port with a one-way valve that protects us as the rescuers from contacting any secretions, but allowing air in, but not allowing that breath to come back at us and get into our face. So the one-way valve is right here. That's what I'm talking about. The mask is clear. This allows us to see if the patient requires suctioning. Many of the masks have an oxygen port that go to them as well. That's you can kind of see it. There's an oxygen port right in here where my little mouse is. That's where we could attach some supply tubing if we needed to some oxygen. Pocket face masks are small enough to store in small response bags, and they're inexpensive. So a lot of times people will carry these style masks. It's usually the device of choice for single rescuer providing ventilations. So again, take your standard precautions. Open the airway, suction if you need to. We can insert an oral airway like that oral pharyngeal or oral airway. So measure. If they're unresponsive with no gag reflex, we can put that in. Connect oxygen to the mask if that's possible. We're going to place the mask over the patient's face and place the strap around it. This does come with a strap as well. We're going to continue to hold the airway open while we're breathing into the mask and create a film or a firm seal between the mask and the patient's face. We're going to seal our lips around the port and blow using a steady, firm breath for about a second. We don't want to breathe too forcefully. Some of that air will miss the lungs and go to the stomach. That can lead to vomiting. We're going to deliver 10 to 20 or 10 to 12 breaths per minute. So one every about 5 to 6 seconds, we're going to breathe for people. We're going to monitor the patient for signs that our ventilation is effective, like they're getting good chest rise and fall. You're going to see some of your breath in this mask. So looking at that kind of stuff. So a pocket mask is a way that we can ventilate patients. Another way we can ventilate patients is using what's called a bag valve mask or a BVM. This is a device that moves air into the lungs when we squeeze this bag that's attached to a mask. The device has a reservoir that gathers oxygen. This is also plugged into oxygen. Each time the bag is squeezed, a high concentration of oxygen is delivered to our patient. The bag valve mask or BVM can be used for both breathing and non-breathing patients. So we have our face mask. There's a patient valve. This is the bag that we're going to squeeze. This is a reservoir, and then we have our oxygen reservoir, and then we have a connection right here that will go into an oxygen tank. So placing this on our patients, standard precautions, so PPE, right? Gloves, mask, whatever you feel like you should be putting on. We're going to open the airway, provide suction if needed, insert an oral airway if the patient's unresponsive with no gag reflex. We're going to connect the BVM to oxygen if that's available. We can still use these if oxygen isn't available. And it depends on if you have one or two people. So if you're the only person there, you're going to be doing this by yourself. But if you have two people that can do airway, we're going to have one person hold the mask while one person squeezes the bag. You might be holding the mask and squeezing the bag as a one person. We're going to try to get a good seal with our fingers. We can use what's called the C. See how she's got a C going right here? And E technique. So we're pushing down right here. We're putting that mask on the bridge of the nose. And if we kind of open the mask up a little bit and put it on, sometimes we get a good seal, a better seal. So you have a C technique around here, and then the E is kind of lifting that jaw up and in. So we're pushing down and kind of lifting up, getting that good seal around this whole area. We're going to squeeze the bag firmly and evenly to move air into the patient's lungs. Ventilating too forcefully, again, is going to allow that to go into the stomach, and it's going to cause vomiting, which can cause aspiration and pneumonia and all this other stuff. We're going to ventilate. Usually, anytime we ventilate somebody, we're going to do it at 10 to 12 times per minute. For this, the EMR level is 10 to 12 times per minute. So we're going to give a breath every 5 to 6 seconds. So make sure you got a good seal and maintain adequate ventilation on it. For the BVM, this is for breathing patients. If they're breathing inadequately, we're going to explain the procedure to them. This can be really a hard thing for people with claustrophobia. The patient may be responsive, so again, explain it to them, kind of coach them. If the patient is seated, that's fine. We can apply the mask to the patient's face while we stand behind them. It is easier to do this if somebody is lying in that supine or on their back position and we're at the head of them. As the patient begins to inhale, we can gently squeeze the bag to assist them in their breathing. So if they're breathing like too rapidly, we can try to get their breathing rate down. We want to try to do this every 10 to 12 times per minute. So every 5 to 6 seconds, we're going to be squeezing like over a second. It can be a difficult procedure, but may keep the patient breathing when otherwise they would stop breathing. So we can do it that way as well. Foreign body airway obstructions. So for this can occur from a variety of different objects. Most common is food. So we are going to do, it's not called the Heimlich anymore. We can't do the Heimlich maneuver. We can do abdominal thrusts. So patients with foreign body airway obstructions fall into two categories: mild obstruction and severe obstruction. So patients with mild obstruction are going to be able to speak and make sounds. They're going to cough vigorously in an attempt to dislodge that object. You should monitor them, but we're not going to act unless that becomes severe. So we're going to encourage them to continue coughing. When the patient has a severe obstruction, they're going to be able to move little to no air in and out. They're not going to be able to speak, not going to be able to make sounds. A lot of times they'll clutch their throat as a sign of choking. So patients who have a severe obstruction are going to require us immediately to act. And for this, we're going to do what's called abdominal thrusts. So we're going to perform abdominal thrusts to dislodge an airway obstruction by standing behind the patient. We're going to reach around the front area between the lower ribs and the navel. We're going to place our thumb of one hand against the abdominal area. You're going to place your other hand over that fist, and you're going to pull sharply in and up to force that diaphragm upwards. That's going to increase our pressure cavity and hopefully push that object out. For obese patients or pregnant patients, like on the screen here, we're going to reach around them and do a chest thrust. We're going to use the thumb side of the hand directly over their sternum. We're going to place the other hand on the first and squeeze directly back towards us to get that object out. So that's for people that are choking. Once somebody goes unresponsive from choking, we immediately start our CPR. So unresponsive patients with a foreign body obstruction are given CPR. So we're going to follow the CPR procedures for that. So if you have somebody choking and you're trying to relieve them from choking and they go unresponsive, we go straight into CAB. So compressions, airway breathing. So you're going to check a pulse and you're going to start compressions. The only difference is when you go, you're going to do your 30 compressions. When you go to look in the mouth or do airway, before you give your 2 breaths, look in their airway or their mouth to see if you see an object. If you see one, you can pull it out. We're not doing blind finger sweeps anymore or anything like that. But that's the only major difference between people with just in cardiac arrest and people that are choking and go unresponsive. When we get to the airway, look in the mouth before you give the 2 breaths, see if you see anything to pull out. So the big picture here, standard precautions. So the patient's moved to the floor. We're going to open the airway. We're going to see if they need to be suctioned. We're going to insert an airway to maintain an open airway. And then we're going to ventilate if needed and administer oxygen if needed. So our stop, review, and remember, the muscles in the chest that allow the patient to breathe are what's called our intercostal muscles. At which location does the actual gas exchange of oxygen from inhaled air to the blood occur? This occurs in our alveoli. And those are those little tiny air sacs at the end of our bronchioles. So we have our oral and nasal pharynx, goes into our larynx, goes into our trachea, goes off into the bronchi, which then go into the bronchioles as they get smaller. And at the end of those bronchioles in our lungs is the alveoli. The preferred method for opening the airway of an unresponsive adult, no suspected spine injury, is our head to tilt chin lift. If they have a suspected spine injury, I know you guys are answering this, jaw thrust maneuver. Most common airway obstruction, the tongue. That's where we would get the snoring from if somebody's laying flat on their back. Okay. So I'm going to stop screen share. Any questions on that? No? That was a big chapter. You guys need a bathroom break at all? Like a 5-minute? Yes, no. So quiet. Nope, nope. Here, nope, all good. Okay. All right. Let me catch my breath here. I just got back from a transport, so. All right, that was 7. Let's get 8 on the screen here. All right, chapter 8, cardiac resuscitation and defib. So this is pretty much AHA BLS provider. I don't even teach this chapter in my class typically when I have teach at the school. So because I have them watch just the HA stuff, which you guys have either all watched or you're going to be watching. So you guys all have your cards. So we'll just kind of buzz through this one as a refresher. So you have the heart, you have cardiac arrest, chain of survival, pediatric CPR, AEDs, and putting it all together, and some ethical considerations to consider. So intro to this, each day approximately 850 Americans die from sudden cardiac arrest, most without ever seeing a hospital. So this means about every 2 minutes a patient dies of sudden cardiac arrest. As a first responder, our immediate actions to restore minimal circulation play a critical role in whether the patient lives or dies sometimes. So this chapter, we're going to kind of discuss interventions that we can perform when dealing with cardiac arrest patients. So we have the heart. So the heart is a relatively simple organ. It looks complicated, right? All this stuff that's going on in here. Whose only job is to pump our blood. This is divided into 4 chambers. So we have our right atrium, which is right here. We have our left atrium, which is here. Our right ventricle, which is here, and our left ventricle, which is here, which is kind of our workhorse. That's what pushes all the blood out. So the right side of our heart, this side, receives blood from the body and pumps it through the pulmonary artery to the lungs, where it picks up that fresh oxygen that is at the gas exchange in the alveoli. The left side of our heart, so this side right here, receives oxygen full blood from the lungs and pumps it through the aorta. So you have your ascending aorta right here that goes to the head and the arms. And you have your descending aorta right down here that then splits off into our femoral. So it goes to the trunk and the legs. So that's kind of it's simplifying this. There's a whole lot going on in here. We have 4 chambers, and the right side receives the blood. The left side pumps it out in general. So there's that description. Cardiac arrest. So the brain is sensitive to decreased oxygen levels. Brain cells begin to die after about 4 to 6 minutes of cardiac arrest. Irreversible damage usually occurs after about 8 to 10 minutes of cardiac arrest. There are many causes of cardiac arrest, but the most common cause, heart disease and trauma in adults, and respiratory problems are most common for infants and children. The respiratory problems lead to cardiac arrest. Because prompt and immediate action is critical to patient survival, we have to learn how to recognize cardiac arrest just simply and quickly. And that's why they switched from ABCs to the CAB, the circulation airway breathing methods a few years ago. So if we want to do as many compressions as we can in this time frame amount. But if you have an unresponsive mental status, we're going to shake the patient and shout, "Are you okay?" Apnea, this means that the patient is not breathing or has a minimal gasping respirations. These are known as agonal breathing, which I don't know why they say breathing because it's not really breathing at all. It's just what happens to your body, kind of gasping for air, like maybe one every 20 seconds or 30 seconds. Cyanosis, again, is that bluish tint to the patient's skin, is usually around the lips and the fingernail beds is where you're going to see that first. Their pulsus, if the patient doesn't have a pulse. If you don't see any movement, the patient isn't moving at all. So these are some signs of cardiac arrest. So we're going to check a pulse in an adult and child. If the child's over the age of 1, we're always going to feel for a carotid pulse at the neck in these situations. So if you have an unresponsive patient, we go to the carotid pulse. If you have a responsive patient, we go to a more distal pulse, like the radial at the arm. So we're going to check the carotid pulse by palpating the carotid artery. We're going to locate the carotid artery by placing our index and middle fingers at the Adam's apple or the trachea in the middle, and just slide it to one side and push up into that neck muscle. You'll feel it pretty quickly. We're going to feel for the pulse for at least 5 seconds, but no more than 10. If we're unsure whether a pulse is present or not, we're going to start chest compressions. For infants, 0 to 1, we're going to use the brachial pulse. That's the one that's under, like, by your armpit. Use 2 to 3 fingers on the inside of their upper arm. And again, we're going to feel for 5 to 10 seconds. So infants, we always use brachial arteries. And then adult and child, we're going to use carotid for unresponsive patients. Chain of survival. This is our chain that you guys have seen if you've taken any kind of CPR class. So the American Heart Association has identified the key components in improving patient outcomes of sudden cardiac arrest and has called them the chain of survival. So the first one, immediate recognition and activation. So this is early recognition of cardiac arrest and an immediate 911 call. Early CPR is training lay people, so just everybody out in the public, to perform bystander CPR while they wait for us to respond to these. We should try to initiate CPR as soon as possible. Rapid defibrillation, rapidly employing an AED or automated external defibrillator on sudden cardiac arrest victims. This is why these are being placed in a lot of areas as well. Effective advanced life support, so early access to higher levels of care like paramedics or ALS, and then emergency departments, and advanced medications and equipment, so they can provide some of the medications and push some of that. And we can play a role in that, just getting ALS en route to the scene early. And then integrated post-cardiac arrest care. This is care that begins in the field that should continue seamlessly into the hospital emergency department, the cath labs, and through the patient emergent and long-term care at the hospital. So getting these patients to a trauma center, cardiac unit, cath lab. Our closest one for us up here in Ely is St. Mary's for that cath lab, and the same for you guys down in Hibbing and in that area. They always try to get them to St. Mary's to the cath lab or Millard one. All right, activating the EMS system. As a first responder, we are responding to the system with this. So effective advanced life support is a link in the chain of survival. So this is us as first responders requesting ALS or requesting air medical if needed, stuff like that, to just get things started early. CPR consists of a time compression and ventilation to provide a minimum level of circulation to a person whose heart is stopped. CPR does generate about 1/4 to 1/3 of a normal circulatory kind of pattern. It may be enough to support life until the heart can be prompted to pump properly again. So after determining unresponsiveness and activating EMS, we should start chest compressions. So this is the CAB method. Compressions come first. So compressions are what moves the blood through the body, with the heart through the body. We're obviously going to place them on a firm, flat surface to get the best possible compressions. So if they're like laying up on their bed or something like that, move them down to the floor. Try to move them right away to an area that's big. If somebody's in cardiac arrest, it's going to be one of those situations where as soon as first responders and the ambulance get there, there's going to be a lot of people, and there's going to be a lot going on around the whole patient, like at the legs and the arms, and there's going to be like maybe a Lucas device involved, an airway going on, an IV being put in, or an IO being put in, some meds being pushed. You're going to need some space to get this done. And doing all that in a tiny bathroom isn't ideal. So use some of those moves that I taught you to drag them out or something like that to get them into a bigger place. Expose the chest and place the heel of one hand on the center of their chest at the nipple line, and then place the other on top. For starting compressions, we're going to kneel at the patient's side, straighten your arms and position your shoulders so they're directly above your hands. And then when compressing, position yourself squarely over the patient's chest. We're going to compress the patient's chest by keeping your elbows locked and using your upper body weight to compress. We're going to go down about 2 inches and allow for full chest recoil each time. And our rate is going to be between 100 and 120 per minute. You can sing. There's a lot of songs on AHA. If you go to the AHA website, you can download a whole list of songs that kind of match the rhythm with this. But Staying Alive, obviously everybody knows that one. The other one, another one, Bites the Dust. I prefer not to use that one. Baby Shark is the new one if you're into that. We're also going to provide initial ventilations to the patient using techniques including the use of a bag valve mask or a pocket mask. Attached to oxygen, we're going to deliver a ventilation over 1 second, ensuring the volume delivered is enough to make their chest rise. So this is where we're starting our 30 compressions and 2 breaths, 30 compressions and 2 breaths. After those 30 compressions, we're going to provide 2 ventilations to the patient with the technique using either your bag valve mask or your pocket mask that you have attached to oxygen if you have that available. Again, we're going to deliver ventilations over 1 second, ensuring that volume is making their chest rise. Allow adequate time for exhalation to take place so waste products can be eliminated from the body as well. For one rescue or CPR, check responsiveness, activate that EMS system, position the patient on a firm surface. If the patient appears not to be breathing, check for a pulse. If no pulse, we're going to start compressions. Open the airway and deliver 2 ventilations after your 30 compressions, and then we're just going to repeat that and pump the AED in there as well when that becomes available. Once the second rescuer arrives, have them grab the AED if you haven't already, or if you maybe don't have an AED, you can start switching off the compressions. We try to switch compressors every 2 minutes or so because it can be really tiring and it can decrease the effectiveness of the CPR that we're doing on people, going down those 2 inches and allowing for that full chest recoil. As ventilations are being performed, if we have a second person or a third person, we can just start rotating out compressions. If you have 2 people to start with, same thing, check responsiveness, activate 911, firm flat surface, position the rescuers around, check for a pulse. If you don't feel a pulse, you go right into compressions, your 30 and 2 cycle. If you do have an AED, you're kind of going through that motion as well. But you're trying to keep up as many compressions as you can. Every 2 minutes, that's when an AED would analyze. But if you don't have an AED, about every 5 cycles of 30 and 2 is about your 2 minutes. So then you would switch roles so people don't get tired doing those compressions. Effective CPR can be monitored while in progress. To verify that compressions are adequate, we're going to palpate a carotid pulse. So if you have an extra person there, if you're doing compressions, they can verify by checking that carotid pulse. If the pulse is present, compressions are adequate. If the pulse cannot be felt, direct the compressor to push harder. Ventilations, so giving somebody breaths, should be producing chest rise in the patient. The patient's chest is not rising with ventilations. We don't have good ventilations. We don't have a good seal. Something's happening. We can reposition the head and try again. Maybe they're choking on something. Patient's skin color may improve with quality CPR, but doesn't always occur. Few patients survive out of hospital cardiac arrest, but signs of returning of spontaneous circulation, or what they call ROSC, return of spontaneous circulation. If you have a patient that is obviously starts breathing or gasping, they start moving around, they start swallowing, they become conscious. Awesome for you guys. It means you just did effective CPR and this person has gone back into a rhythm. Provide the patient with some level of circulation until advanced care arrives. Good CPR is the patient's best chance of survival. And they can always become unresponsive again and go right back in. So just be prepared to start CPR again. So your CPR technique may be perfect and still cause complications to the patient. Some common complications that are seen is you are going to fracture ribs from compressing the chest. It's pretty common to hear and feel ribs cracking while you're performing compressions, especially these older, fragile patients. You're going to feel that on the first probably 2 to 3, maybe 4 compressions, and it'll be kind of crepitous when you're doing compressions. But remember, they can't feel that. At this point, they are dead. So you're doing this to get them alive again. So just know that that's going to happen. If the ribs are fractured, the broken ends may puncture or lacerate a lung or cause a lung to collapse. So no, that's a thing too. But how are we going to know while we're doing this? We got to do compressions and we got to do them to get the heart started again. So it's this inevitable chain of things that could happen. Even though the completions or complications are significant, they're not the concern while we're doing compressions on somebody in cardiac arrest, because we're trying to get the heart to start. So recognizing and activating EMS early, some key points: push hard and push fast, 100 to 120. Switch compressors often. We try to do that every 2 minutes. And then limit interruptions in compressions. So we're trying to limit these to like 10 seconds or less. Adequate CPR circulation takes several compressions to begin. And once we interrupt it, it takes more to achieve that again. So the less interruptions and compressions, the better. So just doing our 30 and our 2 breaths, 30 and 2. We're going to keep that going as long as we can. Pediatric CPR. So for kids, the kids' chain of survival is prevention. So responding to a call for a child in cardiac arrest it can be very stressful, but our actions can help. So performing CPR in infants and children is slightly different than adults. So we have to account for the differences in anatomy and how big are they really. Like the new versions of this stuff that's coming out is for a child, you can do the palm of one hand or 2 hands, depending on how big the kid is, because you still want to get down that 2 inches, just like an adult, and chest recoil. For infants, a lot of times we're taught the fingers for EMR level and up. It's usually the thumb encircling technique. If it is a big infant, you can also use the palm of one hand. Just you're trying to get down 1.5 inches to 1/3 of the depth of their chest on the infants. So starting it out with prevention and then early CPR. Hopefully lay people are doing CPR. Prompt access to emergency response system would be us, them calling 911, and we're coming. Rapid pediatric advanced life support. So we're calling in ALS to come as well. And then the integrated post-cardiac arrest care at the hospital, just similar to the adult. So different anatomy and etiologies of cardiac arrest necessitate adjustments for pediatric patients. So maybe they're in respiratory arrest because they drowned. We're trying to get their airway back. That brings their heart rate back. A heart rate of less than 60 indicates CPR in pediatric patients. So if they have a heart rate of less than 60, we're actually going to start compressions. With pediatric patients, as an EMR, we should resuscitate first and activate EMS later, because typically it's a respiratory issue, not a cardiac issue, because we want to get the adult chain of survival is we want to get the AED there as promptly as possible, because it's usually a cardiac issue in adults, but not so much in kids unless they have like a defective heart or they're like, we know what's going on with them. So we're going to start resuscitation first and then call 911. So resuscitate now, call later. So the most common causes of cardiac arrest in pediatric patients are airway and breathing problems. So calling for help will be secondary to initiating CPR for these patients. If you choose to between calling for help and starting CPR, start CPR and perform at least 5 cycles before you call for help. Research tells us that immediate CPR provides the best chance of survival for pediatric patients. Although advanced care is still important, it's secondary concern when dealing with pediatrics and cardiac arrest because it's usually a breathing problem, which leads to respiratory arrest, which then leads to cardiac arrest. It's not usually a heart problem like cardiac arrest, like their heart stopped because they have blockage in there. So again, for these pediatric compressions, same as for the adults, move to a firm flat surface. We can put a pad beneath the torso that puts their head in that sniffing position. For hands, again, child, patient, expose the chest, heel of one hand. If it's a bigger kid, you can use two. For infants, 2 fingers at the center of their sternum or the thumb encircling technique. We're going to press straight down, approximately 1/2 the depth of the chest of a patient's torso, and allow for a complete recoil. The compression rate is the same, 100 to 120. If we put something behind their torso, it's going to open their airway up, like putting a pad back here. It's going to get their neck into more of a sniffing position. They have a larger head in proportion to their body. So if we don't have a pediatric size BVM and other equipment, we can use the adults. Remember, we're just giving people enough air to get their chest to rise and fall. So enough air to get their chest to rise, then we stop. We don't want to blow their little lungs apart when we do this. So we're going to ventilate steadily and slowly over 1 second, just enough to get that chest rise. Overventilating or being aggressive with ventilations can cause serious injury to their lungs, which we don't want to cause. Always allow for adequate exhalation after each ventilation because we're trying to eliminate that waste product as well, get that carbon dioxide out. So it's very similar to the sequence as the adult. Check for responsiveness, signs of life, position the patient. So supine, firm flat surface, check pulse, start compressions if you don't feel a pulse. Open the airway, deliver your 2 breaths, and we're going to repeat that 30 and 2 compression cycle. 2 rescuer is the same thing, except for in children and infants, we move from 30 to 2 to 15 and 2 because it's more likely a respiratory breathing problem, not a cardiac problem like adults. So adults across the board, 30 and 2, but infants and children across the board for everybody, 1 rescuer. If you're there by yourself, is 30 and 2. But once you have multiple people involved with this, infants and children, we're moving to 15 and 2. So 15 compressions and 2 breaths, and we're going to rotate that cycle. The thumb encircling technique, I'm sure you guys have seen this, but this is the most effective for infants, placing your thumbs on the sternum at the nipple line, encircling your hand around them and squeezing down and allowing for full chest recoil. That's you can do the 2 fingers technique, but this is, they say, the best one to do for infants. Complications, same thing. We can fracture ribs, we can collapse lungs, hypothermia. So we want to maintain warm. So once we have the chance, we can put a blanket on them. But same complications we have as the adults. So AEDs, automated external defibs. So these come in a variety of different manufacturers. Most cardiac arrests are not caused by a mechanical stoppage of the heart, but rather an arrhythmia that causes the heart to beat so abnormally that it can't pump the blood. This type of arrhythmia can be resolved by a process called defibrillation. So it's when the heart is shocked with electrical activity in order to reset the rhythm to a normal pulse producing rhythm. An AED is a device that recognizes lethal arrhythmias through the pads that are placed on the chest. When that AED analyzes the patient's heart rhythm, it determines if it's shock or non-shockable. So AEDs come in a lot of different models, different manufacturers. They're all very similar. The first thing we do is turn them on. They're in a lot of places now. We know that. We've seen them as we're walking around airports and malls and schools and that type of stuff. And there are public access defib programs out there that are putting more out there into the field. So when it comes to lethal arrhythmias, there are 4 that causes a patient's heart to go into cardiac arrest. There's asystole, or what's called flatline on the screen, like the movies. They're like all the way across. The heart has no electrical activity at all, therefore no pumping is taking place. Pulseless electrical activity, or what's called PEA, this is the rhythm of the heart is working fine, but there's no mechanical pumping taking place. So they'll look like they have a pulse on the thing, but there's actually not a pulse that matches the pulse. You have ventricular tachycardia. This is a very fast and inefficient rhythm that may cause or produce a pulse, but it does not produce a pulse that the patient is in cardiac arrest. So it can produce a pulse, it cannot. Ventricular fibrillation is a completely disorganized rhythm that does not produce a pulse, and the most common rhythm in cardiac arrest patients is VFib, they call it. Of these rhythms, VTAC, or ventricular tachycardia, and ventricular fibrillation, these two are the only two that the AED is going to respond to. So if the AED says shock advised, they're in one of these two rhythms that the AED can shock and hopefully push them back into like a normal sinus rhythm, so their heart starts pumping normally again. If they're in a systole or PEA, this is going to say no shock advised. It's not going to recognize that rhythm to give it a shock. It won't help at all. So we are doing compressions in order to get them into one of these two rhythms so we can shock that patient so they come back into normal sinus rhythm is the whole idea of compressions, to keep them in these two rhythms. Usually this is the rhythm people are usually in, is VFib. Safety with these are generally safe, but can harm people if they're touching the patient. We're never going to apply on an AED on a patient with a pulse. If the patient is in like ventricular tachycardia with no pulse, the AED will shock them, and that can be fatal. So if they have a pulse, we're not going to put this on them yet. We'll have it on standby. An AED delivers a significant amount of electricity, usually around 200 joules, and can be harmful to someone who is in contact with the patient when they're shocked. So if we're using these, we want to make sure that the patient running that or the person running that is clearing that patient, making sure nobody's touching that patient as they hit that shock button. The American Heart Association recommends applying the AED immediately if you have one available. If you have like a cardiac arrest, no pulse situation. If you have an AED immediately available, if there's multiple rescuers present, CPR should be started and we should prepare the AED and put it on. First thing we do is turn it on. So turn on the AED. This is done by pressing the on button, or simply some of them you open the lid on some of the models. Attach the pads to the chest. There'll be pictures on the pads to put them on the bare chest. One usually up on the right over the collarbone by the shoulder, and one on the left side of their abdominal area. We're going to clear the patient and analyze the rhythm. Some AEDs analyze automatically, and others require you to press an analyze button. But most of the ones that are out in the public should analyze on their own. The patients cannot move while the AED is analyzing, so CPR has to be discontinued while it's analyzing, or it can give a false rhythm. If a shock is advised, we want to clear that patient, tell everyone to stand clear and ensure that no one is in contact with that patient. We're going to press the shock button. Typically, the patient's going to display a full body muscle contraction when that is delivered, so be prepared for that. And then we're going to resume CPR immediately after the shock. After 2 minutes, the AED is going to analyze the rhythm again. So every 2 minutes, that AED is going to say analyzing rhythm, stop CPR, analyzing heart rhythm. And that's your cue, if you have multiple people, to switch people doing the compressions to get fresh people in there. The American Heart Association also states AEDs should be attached to any patient in cardiac arrest. Many AEDs come with pediatric pads that adjust the energy from shocks to the appropriate pediatric dose. If the AED has these pads, we can use them on the patients that are younger than 8 years old. But we want to follow the manufacturer's guidelines for these. So if you have a patient that's a pediatric patient, usually considered 8 or under, and you have, depending on what pads you have, sometimes they're in the front, sometimes they go on the back, front and back, or sometimes they're placed like the adult ones. If you don't have pediatric pads, you can use an adult AED on an infant or child. So some of them will have an attenuator, so they'll say press the pediatric button if you're dealing with a pediatric patient, so it can adjust the level of joules that it gives. So there's an option on some AEDs with that as well. Just depends on what AEDs you guys are working with. Continuing quality assurance. So any call involving an AED should be reviewed. This is usually done with the involvement of a medical director. Most AEDs are equipped to transfer data to a computer so we can plug them in and retrieve our data off of them. So the service should develop some kind of guideline for routine checking. Not so much the service you guys are working for, but this would be for the EMRs coming after you when they're using their AEDs, called post-call evaluation of them. So we know if they're effective and what happened. Quality improvement, quality assurance stuff. So putting it all together, observe the patient for signs of lifelessness, scan their chest for breathing, check a pulse, activate the EMS system, request ALS or advanced life support. So paramedics, if you have that in your area, send someone to get an AED if you know there's one close by. We're going to move that patient to a firm, flat surface. We're going to check pulse for up to 10 seconds, but no more than 10 seconds. If no pulse, we're going to begin compressions. If you have an AED, you can attach that. Then we're going to do our 30 compressions and 2 ventilations. And we're going to continue CPR and follow the prompts of the AED until help arrives. The ambulance arrives. If CPR and defib return pulse or cause spontaneous breathing, we might have to continue rescue breathing if appropriate or if necessary. So help them out a little bit. We can apply high flow oxygen. Usually this would be like a non-rebreather set at 15 liters per minute. We're going to monitor the pulse carefully and keep the AED pads attached to the patient because a lot of times they will go unresponsive again as well. And we might have to use it again. So don't start unhooking things quite yet. Ethical considerations of cardiac arrest. So some dilemmas can arise both before and starting CPR. Often the question is about whether or not to start CPR. Do we start it? Do we not? So there are some protocols that we can follow a little bit with this. Some obvious signs of death. So when we're trying to determine whether or not we start CPR, say you guys are out and you're going into a client's home and you walk in and you're like, oh my God, you call 911. Do you start CPR or not? When should you initiate it? So if that patient is in rigor mortis, which is a stiffening of the body after death, we're not going to start it. That's an obvious sign of death. If they have dependent lividity, this is pooling of blood in the lower areas of the body. This is a result of gravity. So if they're like laying on their back and you see a pool of like a darker area on their back, they've been down for a while, we're not going to start CPR. If they have a gross dismemberment, like a decapitation or a massive damage to the body that's incompatible with life, we're not going to start CPR. If they have a DNR order, a do not resuscitate order, usually written by their physician for the patient, usually these patients have a terminal illness or like cancer. When a valid DNR, which we'll talk more about what these are coming up in some of the chapters, when a valid DNR order is presented to you, we're not going to initiate CPR. So we just got to follow local protocols concerning the initiation, resuscitation stuff. When a patient dies, we're going to turn our attention to the family of the patient. They're going to be emotional, so we're going to start providing emotional support for them and their loved ones, whoever's there. They might be a little bit aggressive or yelling. It's not at you, it's at the situation, going through their stages of anger, denial, all of that. Okay, so some terms. So we have atrium. These are 2 upper chambers of the heart. Your ventricles are 2 lower chambers of your heart. You have a right and left for both of those. A pulse is the sensation of a change in pressure or a beat in the arteries created by a contraction of the heart. That's where we feel a pulse rate, usually over a bone on one of those major arteries. Cardiac arrest is the failure of the heartbeat, so there's no pumping. Apnea is no breathing. There's not breathing. They're apneic or not breathing. Agonal breathing. This is infrequent, irregular gasping respirations, usually associated with respiratory or cardiac arrest, which happens post-cardiac arrest. So if they're still in the agonal breathing, we got a good chance if we start CPR to hopefully get them back. Cyanosis is a bluish tint to the skin, especially around the lips and fingernail beds, resulting in hypoxia or lack of oxygen. AED is a device designed to recognize fatal heart rhythms and send an electrical current through the chest to correct the problem. CPR is timed chest compressions and artificial ventilations designed to maintain minimal circulation in a patient with cardiac arrest. The xiphoid process, this is that little small piece of cartilage at the bottom of the sternum. So a small protrusion at the inferior end of your sternum that can actually, if we do compressions too low, we could snap that off potentially. Arrhythmia is an abnormal, or an abnormal electrical heart rhythm. Defibrillation, this is an electrical shock applied to the heart to correct lethal heart arrhythmias. So it's usually going to be in a VTach or VFib, ventricular fibrillation or ventricular tachycardia is what the AED is going to use that for. PAD is a public access defibrillation, so a program that distributes AEDs to lay rescuers, especially in areas of high public traffic use like malls, airports, schools, that kind of thing. Rigor mortis is a stiffening of the body after death, usually starts in the joint, like the fingers and the jaw. Dependent lividity is the pooling of blood in the lower area of the body after death. So again, if you see those, we're not going to start compressions. So the upper chambers of the heart. I know you guys all answered this right. Atria, right? Atrium. The left ventricle pumps blood to the body. That's our workhorse. The bluish tint to skin, especially around the lips and fingernail beds. That's our cyanosis. Jaundice is going to be the yellowy color. Diaphoresis is going to be like pale, cool, sweaty. And cirrhosis is a liver disease. I don't know why that's on here. That's funny. The appropriate rate of compressions for adult CPR would be 100 to 120 compressions per minute. All right. Stop share on that. How are we doing now? Am I still awake or am I putting you out? No? Okay. Sorry, my cat's up here behind. That's why I blur my screen. He just came racing through the room and knocking a bunch of stuff over. Okay, so we have that one done. So we have 9 and 10 left tonight, which I'm going to actually share my screen and show you. Let's go with this. So I put these on there for you. So this one is, these are from the National Registry, patient assessment, medical and patient assessment trauma. So this is like a template of like how you start working your way down through scenes when you get there, right? So we want to make sure that we have appropriate PPE on. Scene size up, we want to make sure the scene is safe. So we're going to be talking about in the chapters coming up, really just this first part right here today. And then we're eventually going to be getting into the rest of this as we go along through the next like 3 or 4 chapters. So keeping these in mind, let's go through 9. So this is our scene size up. And what this one is the sheets that I gave you. You can print those off if you need to. So we're going to be going through scene safety, physical hazards of the scene, mechanism of injury, nature of illness, resource determination, number of patients, and standard precautions. So as we look at these sheets, we have our PPE, scene safe, mechanism of injury, additional EMS, and we have additional things that we add on here like C-spine precautions. This is our scene size up right here. This is chapter 9 that we're going to be talking about. So as a first responder, we're usually the first ones to arrive on scene, or you're going to be the first ones walking into these clients' houses. Let's figure out why that's paused. Hang on, I'm going to stop share for a second, or reshare. Okay, is that better? Hopefully. All right, so as a first responder, we're usually going to be the first ones to arrive on scene in these emergency situations, or you might be at your client's house and you're the first one on scene there when you're in there. So this brings responsibilities, and we can also kind of be placed in the path of danger when it comes to certain things as well. So keeping ourselves safe is paramount as well. So doing a systematic approach at each scene and doing a complete scene size up and working our way down these sheets is going to help us out a little bit. So with this is our scene safety, standard precautions. We're going to talk about each one of these. Resource determination, number of patients, mechanism of injury, and then there's the C-spine one that we'll get to. So scene safety, when it comes to scenes like this, as a first responder on scene, we have to carefully scrutinize our area for dangers. So if our scene size up should begin as we get the call, I think, right? And as we're going to a call, we're driving a lot of times our personal vehicles, making sure that we have our seatbelt on, things are safe. When we get there, we're observing the scene as we approach, maybe things that are leaving, people are running around, things happening. If we see stuff like this, a telephone pole apparently snapped and hanging by wires, we're probably not going to go near that. If you see a tanker truck rolled over in the ditch, we're probably not going to go near that. A large fire at a warehouse. Turn the corner and people see people running from the scene. These are all things that we need to be aware of that can potentially have specific dangers for us. Violence. We obviously want to avoid placing ourselves in these dangerous situations. So the nature of responding to emergencies may put us in situations where danger can present itself unexpectedly sometimes. So your observations and tactics heading into a scene, and while we're on scene, just keeping your situational awareness and making sure you're being safe about stuff. Begins when you start your observations, obviously. So what are you looking for when it comes to violence? Are like signs of fighting or violence, loud noises, loud voices, weapons, broken glass, stuff like that. Signs that alcohol and drugs are present or in use in that area. An unusual silence. So sometimes things can be like too quiet, right? You get up and you feel like it should be more busy than this. So while we feel the need to rush into scenes to start patient care, because this is why we're doing this, right? We want to do patient care. Sometimes we have to resist that approach to go in and cautiously place ourselves in a situation where like the scene is not safe for me to go in until maybe the electrical panel is turned off or the power to that pole is turned off, things like that. So we want to make sure that we're keeping ourselves safe, because if we go in, we don't want to be another patient for our coworkers. So if we approach a scene and identify violence, we immediately want to retreat. We can run away from stuff if the scene is not safe. That's not called abandoning your patient. That's called scene not safe, get out. And notify dispatch that law enforcement is needed on scene. Sometimes we know some of the places that we go, and we make sure law enforcement's en route as we go to. A lot of times dispatch may also know that the scene is unsafe, so they're dispatching law enforcement as well. So always be aware of your surroundings, because violence can erupt suddenly. So some of the tactics we talk about a little bit are distraction. We can use equipment or other items at the scene to create distance between us and our aggressor. This is usually done in conjunction with getting out of there and retreating, running away. There's cover and concealment. Cover is taking that position behind an object that hides you and your body, provides protection. That's going to be like an engine block, a wall. There's concealment. This is like a bush. It hides your body, but it doesn't provide protection from you from like a flying bullet. And then we can retreat. This is the preferred response when things get violent, is run away. And it's fine. We can come back with more people in a little bit. Physical hazards at the scene. So maintaining a safe distance from hazardous materials, and we'll talk more about hazardous materials too, and we'll talk about like what an emergency response guidebook is and that kind of thing, one of our later chapters. But maintaining a safe distance from a hazardous material, identifying it prior to entering the scene. If you suspect hazardous materials are present, we want to stay uphill and upwind from the scene until it's safe to go in. We have to be prepared to respond to terrorist incidences in some places, probably not Ely where we are, maybe not Hibbing, maybe not Virginia, but some places where we might be. And these involve chemical, biological, radiological, and explosive materials. We'll also talk more about those. But specifically, terrorist incidences include a large number of patients, a scene that may extend over a very large area, a large-scale operation run by incident command. So we want to think carefully before entering some scenes and about how to avoid any materials that have injured people, Secondary devices, they're a delayed detonation. These are a secondary explosive device designed to injure us as rescuers coming in to disrupt the scene even further. So just know that things are out there like that happen, targeting us. Motor vehicle collisions, these can pose dangers ranging from spilled gas, chemicals, jagged metal. The most deadly hazard at the scene of a motor vehicle collision is passing traffic because people are watching what you're doing, they're rubbernecking, they run into you. So if you're required to wear some protective clothing when working in or near traffic, a lot of times you have to also have your vest on, your ANSI approved vest, safety vest. Protection from traffic hazards includes properly placed police cars or fire department vehicles. Can kind of shield between the location of the passing traffic. Extremes in weathers can pose a hazard to our scenes as well. Extreme heat or cold may pose a risk to us and our patients. So protecting ourselves and wearing the right equipment as we go out there. And other hazards to consider, like steep slopes, fires, unstable vehicles, all of these hazards have to be addressed before we go in and deal with these patients. Mechanism of injury, nature of illness. Typically, mechanism of injury is going to be more trauma, and nature of illness is going to be more medical situations. So we can use our initial observations of the scene for more than just determining if the scene is safe. So if we can use if we have like this instant right here, like we know this is probably a mechanism of injury, this is a car accident. And judging by this, they got rear-ended, maybe they rolled, so we can kind of start guessing what's going on with our patient injuries, coming up with our index of suspicion of what's all going on with these patients. So mechanism of injury is the physical force or forces that cause a patient's injuries. We're going to learn to examine some forces and develop an idea of the patient's injuries. This is referred to as index of suspicion, like I said. The general rule when determining mechanism of injury is the faster the speeds involved in the injury, the greater the height of somebody falling, the more injury that potential we see in these patients. So some of the injuries from motor vehicle collisions. So we have head-on collisions. The occupant in the vehicle is thrust forward. Level of injury depends on the speed or velocity of the vehicle and whether the occupant was restrained wearing a seatbelt or not. The greater the speed, the greater to obviously potential for injury. Restraints will generally reduce injuries that we see. Seatbelts and airbags greatly reduce injury in head-on collisions by preventing the occupant from impacting the steering wheel, the dashboard, or the windshield. If the occupant is not restrained, we're going to see them take one of two paths. They're going to go up and over or down and under. They're going to go up and over, which is this. So these for unrestrained occupants is the occupant traveling forward upon that impact. They're going to go up and over the steering wheel or the dashboard, striking their head on the windshield. So injuries in this are going to usually be head, neck, chest, and abdominal injuries. Or they're going to go down and under, take that path. The unrestrained occupant continues forward upon the impact, going down and under the steering wheel or dashboard. And that's where all your legs are going to be involved. So your abdominal area, your hips, upper legs, knees, lower legs, ankles, all of this is going to be impacted. So that's the front end collisions or head-ons. For rear end collisions, this is causing the patient to spring backwards. This can cause a common injury called whiplash as the head is violently thrown backwards and then moves forward. Whiplash can be reduced by properly positioning headrests in vehicles. So this is going to be a rear end collision where the head gets thrown backwards. So having a good headrest right there is going to prevent that. We have side impact. So this impact or T-bone collision, it can cause serious injuries. A lateral impact can cause head and neck injuries. Force of the impact can directly impact patients seated in that vehicle, maybe on that same side as well, more of an impact. Imagine driving through an intersection, your car gets hit on the driver's side door. That door is probably going to collapse in on you into the passenger compartment and hit you on your left side. So the impacts are going to be likely causing internal damage, abdominal, chest organ damage. It can be a lot of damage going on, kind of this whole area. We have rollovers. Rollovers can have multiple injuries because the vehicle sustains injuries and impacts from multiple directions as it rolls. end over end or side over side. Items inside the vehicle can also cause injury. They become airborne inside the vehicle and start hitting you. Patients who are restrained or remain inside the vehicle during the collision may suffer only minor injuries or no injuries at all. And those that are unrestrained can be ejected from the vehicle as it rolls. Ejections from a vehicle are associated with a serious injury and a lot of times death. Be thrown out a window or a open space. You have rotational collisions. Rotational collision is a vehicle that is struck usually like on a corner and then it spins. This can result in a secondary collision with other objects or vehicles that are stationary, trees, poles. So if you get hit, you spin around, you hit something else. So as with rollovers, this can cause multiple injury patterns are likely with patients that are involved with rotational collisions. Motorcycle collisions, these can cause severe injury and death. Currently, less than half of the states in the U.S. have laws requiring riders to wear a helmet. The likelihood of death and serious head injury is significantly higher for those not wearing a helmet. Severe injury patterns can occur with this. We have ejection over the handlebars. So if a motorcycle hits something on the front end collision, the rider will often be thrown up and over the handlebars when this occurs. The rider's legs often hit handlebars, causing fractures, and the rider then impacts the ground, causing other injuries. You have side impact. This is the impact that causes the rider's hips and legs to be injured. Laying the bike on the ground, this is actually a method taught to riders to attempt to avoid collisions. The rider will turn their bike sideways and bring it to the ground to avoid frontal impact. This usually results in lacerations, abrasions, burns, stuff like that in the areas that are less severe than the result of a frontal impact, but it is a technique they're trained to do. Falls from height. So these range from just falls in general. They range from tripping to falls from significant heights. So like the patients you guys are working with, they're probably gonna fall. Right? Let's just be honest with each other. So slips, trips, falls. Sometimes people just their hip gives out or their knee gives out and they fall to the ground. So falling from a standing position, which can cause fractures, just like any kind of height in some of these patients you guys will be dealing with. So falls range from tripping to falls from significant heights. We're going to respond to a lot of different types of these. We get called out for this all the time. Height, significant for adult if a fall is greater than or equal to 20 feet or more. As significant for a child if the fall is from 10 feet or 2 to 3 times their height. So if you have a little kid, 2 to 3 times their height would also be a significant fall. Part of the patient that struck the surface, what hit first? Was it their head? Was it their feet? And the surface the patient fell on, did the patient land on a hard surface like concrete or did they land on grass? What did they land on? And whether anything broke their fall. So they hit anything on the way down to cause additional injuries and rotation? So if a patient lands on their feet, they may have fractured heels, legs. It can go all the way up to the spine. If the patient trips and tries to catch themselves by stretching their arms out, sometimes it can be the wrist, arm, shoulder. A lot of times these older folks, if they're falling down, and osteoporosis and stuff like the bone diseases people are going through can make more bones brittle and they fall and they can break a hip. A lot of times it's the outer side of the hip or it's the femoral head where it goes in. That's what's broken. So things can happen just by tripping and falling. Determining a number of patients and resources. So this part would be how many people do you need there, right? So a resource determination involves everything that we discussed so far. Before you go into the patient side, making sure that you have everything you need heading your direction. So if you need ALS, you're requesting them. If you need a helicopter, you're requesting them. If you need hazmat, you're requesting them. Fire, if you need the power off, you're calling the power company, that type of thing. As a first responder, we're going to respond to calls with sometimes dozens, some maybe several hundred patients. You never know where you're going to go. Look at the bus accident in Cherry. They didn't think they were going to have that. More frequently, you're going to respond to calls with 2 to 3 patients typically, like, 2-car accident, 3-car accident. So those calls can pose logistical challenges for care of all the patients because now we're like in an MCI situation. So the MCI, or multiple casualty incidences, is when the number of patients exceeds the resources that we have available to us. So if we have just us on scene and there's 6 patients, we need to start triage, right? So having 3 critical patients on scene can fall into the category of additional resources. Usually it's 1 patient per ambulance. So we're calling additional ambulances, 1 for each patient. If it's minor stuff going on and it's an MCI, sometimes we're sending 4 patients with an ambulance. But look at the scene, see what's going on, what additional things that you need help with, how many patients do you really got going. Standard precautions is our PPE. So this is keeping us safe from what that patient might have. So while performing the scene size up, identifying protection needed to prevent you from becoming contaminated from diseases, etc. As we approach the scene, we should be putting on whatever layer of PPE we need to be putting on. Minimum is gloves, right? So gloves, if you have spraying stuff like blood, maybe we want to put on some eye face shield, maybe a gown if we have time to do that. But determining what the protection you need to put on and putting on that protection. You guys might be dealing with patients that are older and maybe wearing a mask, that type of thing. So whatever protection you think you need to put on is your PPE, personal protective equipment, is your standard precautions. All right. This one is your call to a scene when a person has fallen off a bridge. Upon arrival, you find this patient. You determine the scene is safe. What other information would you like to have? So probably they fell, right? So height of the patient fall. What did they land on? Did they hit anything on the way down? And how did they land? How can we access that patient from where they're at? What additional resources do we need for that? You verify that there is 1 patient who's fallen about 50 feet to the ground below, and we have no way of accessing that patient. So now we need to find additional resources. So up in our area, we have St. Louis County Search and Rescue. There's things that we can call in a dispatch for. So additional resources that we needed might be high angle rescue. There's a river there, could be a boat, who knows? From the blood present, so level of standard precautions, we're at least going to need gloves, right? Because he's bleeding over here and bleeding here. That's airway. I might even put a mask and face shield on in case we need to suction. Stuff like that is things we need to think about to keep ourselves safe in the long run. All right, so when a responder believes that it is highly likely a person's injury was caused by a mechanism present, it's referred to as index of suspicion. So we go to a car accident and we're immediately thinking, these are all the things that could be wrong with that patient. That's our index of suspicion. And then we can start ruling them out as we go. An automobile crash that propels occupants forward in a vehicle is referred to as a head-on collision. In a motorcycle crash, what type of injury should the EMR suspect if it was an over-the-handlebar ejection? This is going to be everything: leg, hip, head, neck, chest, abdomen, because their legs are going to be hit, but also they're going to hit the pavement and every other stuff's going to be hit. So it could be all the above. So it's everything, all the above. Okay, stop screen. So far, so good? Okay, what comments do we have on here? Because you probably didn't see. Okay, perfect. All right, those sheets making a little bit more sense that I sent out with how we're starting. So that was our kind of our primary or our scene size up situation going on with that chapter. So now we have chapter 10, which is our last chapter of the night, which is primary assessment. And this one's pretty short, but so primary assessment is going to be after we do our PPE, scene safe, mechanism of injury, number of patients, additional resources, maybe taking C-spine manually. Now we want to do the next step. So this is the most important part of patient care, is our primary assessment. So the 8 components of our primary assessment, and we'll talk more about these obviously in depth as we go through, but general impression. So this is how the patient looks to you as we approach. It doesn't necessarily require any special training or equipment. You guys can just look at a variety of people and say that person isn't feeling very good, right? So it's an opinion or impression formed by what we see on how that patient looks. Does the patient have an apparent life threat going on? Does the patient appear to be in a serious condition? Once we make contact with the patient, we can kind of tell what's going on. Ask them, hey, my name's Alyssa, how's it going? Whatever they tell you is their chief complaint. The chief complaint is then documented in the patient's own words, like this guy, my chest hurts. The patient is not able to communicate with you, attempt to obtain information from family and bystanders, but if they say my chest hurts, that's our chief complaint that they gave us. That's what it would be. So some serious signs for general impressions, if they're unresponsive or if they have an altered mental status, if they're anxious, agitated, or sleepy, this is getting into they're kind of shocky. Maybe they got something going on. Cool, sweaty skin, right? We don't just normally sit there on the couch with cool, sweaty skin. Something's going on internally. Position indicating chest pain or difficulty breathing. And when we talk about like the cardiac chapters and respiratory chapters, we'll talk about more what these are, but that would be like the tripod position. Somebody's sitting there like leaning forward because it's hard to breathe. If they're in severe pain, a severe hemorrhage, so they're bleeding, like there's blood squirting out everywhere. Those are some serious signs. Not so serious signs, they're awake, they're alert, no apparent difficulty breathing, no chest pain, normal skin color condition, they're relaxed, they're talking to you. Okay, now we have some time. We're in a non-serious situation. We can gather some more information. So that's our general impression. Getting our chief complaint. AVPU. So this is determining level of responsiveness or level of consciousness, our LOC. So the four widely accepted levels of this are what we call AVPU. So we have alert. Patients awake, they're aware of their surroundings, they know where they're at, they know who they are. So we kind of go with like they're alert and orientated times 4, person, place, time, event. They know what's going on. If they don't, and they're laying there, we work our way down through this. The next stage is verbal. Patient may appear unresponsive, but will respond in some meaningful way with a verbal cue. So, hey, are you okay? They open their eyes. The patient might talk or make a noise. If they're not alert, they might be confused or just jumble incoherently, but they open their eyes and are looking at you. That would be verbal. P would be pain. Patient does not respond to us verbally, speaking, shouting, walking up, hey, are you okay? Nothing. So we go to the next thing and we apply a painful stimulus, which is either pinching the muscle at the base of the neck, doing a sternal rub. We can pinch their fingernail. If they respond to any of that in any way, they would be responsive to pain. Or if they're together, we go through this whole list and they got nothing, they're just unresponsive. So we have alert, verbal, pain, and unresponsive. Those are our 4 levels of consciousness. I'm going to spell those out right here for you guys. So under alert, patients awake, aware of their surroundings. They know who they are, where they're at. If they're verbal, they may appear unresponsive, but will respond in some meaningful way with verbal cues. Pain, they don't respond at all to verbal cues, but if we apply a painful stimuli, then they respond, or are they not responding altogether, which would make them unresponsive. Point of emphasis for this, mental status is a key component of primary assessment and provides us an early indicator of the patient's condition. So we use that mnemonic AVPU to categorize that level of responsiveness. So then we move into airway. Is the airway patent, which just means open? Is the airway open? Are they breathing? If it's not, we need to open the airway, and we open the airway by using the head tilt chin lift or the jaw thrust if we suspect a spine injury. We can look to see if they need to be suctioned. We can insert an airway. So clearing any obstructions that you see out of there. For breathing, we have to ensure that the patient is breathing adequately as part of the primary assessment. So adequately deals with the rate and the depth of their breathing. Signs of hypoxia, which is lack of oxygen. For this is knowing that their breathing is not adequate and should be corrected. So we're gonna probably have to get the bag valve mask out and start ventilations. Agonal breathing, again, we're not going to mistake that with regular breathing. It's not adequate. Most of the time, these patients are exhibiting signs of hypoxia as well because agonal breathing is not really breathing. If at any time breathing is not adequate, we're going to ventilate that patient using high flow oxygen. Get our bag valve mask out, hook it up to 15 liters, and start bagging them. We move to circulation, which is C. So the key element of assessing circulation. If the patient is unresponsive, it does not appear to have respirations, check the carotid pulse, no more than 10 seconds, and we're going to start CPR, start the CAB method. If a pulse is present, we're going to assess the rate and quality of that pulse. Is it fast? Is it slow? Is it weak, like you can barely feel it? Or is it bounding, like you can really feel it? We're going to look for signs of inadequate circulation. This is also called hypoperfusion, also known as shock. We're going to talk more about that when we get to trauma. We're going to observe the patient for severe life-threatening bleeding and correct that if indicated. We're going to observe the patient's skin condition to see if the skin is normal color, warm and dry. When the patient's not getting good circulation, their skin's going to become pale, cool, and sweaty, or what's known as diaphoretic, which is this word, that diaphoretic word. If a massive hemorrhage is present, so it's bleeding that's going to cause shock or death rapidly, such as bleeding from a femoral artery, it's appropriate to stop that bleeding before we do our ABCs and assess anything else, because they're going to bleed out before we can get to airway. So multiple people on scene can be doing multiple tasks if you have more people, but if you're by yourself, this is kind of how we got to do it. If you have abnormal findings when assessing circulation, the patient may be in shock. We'll cover that when we get to that chapter for shock, hypoperfusion. So with primary assessment, ABCs may be performed in order based on the patient's injuries and priority. It's kind of a step-by-step process. Some situations may require that process to vary a little bit. Rare occasion on the hemorrhage, and I'll bring that sheet back up and I'll kind of show you where that is on there. We're going to expose to perform a complete assessment. We're going to expose all pertinent areas of the patient. We may have to expose the chest to assess for breathing and signs of trauma, but we may need to expose other areas as well if we suspect injury. I always take patient's modesty and the environmental condition, like cold weather, into your decision making. And remember that we cannot treat what we can't see. I tell my students that if you have a trauma patient and it's a legit trauma patient, sorry, that patient is going to be trauma naked, because I want to see what is all wrong with that patient. We need to start fixing stuff. That doesn't mean you should be just stripping your old ladies down because they fell and broke their hip, right? So don't take it as that, but that is a trauma, but we don't need to do that. Priority updating incoming US or EMS units. So updating the patient's condition over the phone. Sometimes dispatch will ask you how it's going. We have working channels that we work with as an EMR that we can then update the ambulance if we're there on scene first and let them know what's going on so they can bring the right equipment in, make it a little bit quicker. Usually it's the patient's age and sex, their chief complaint, level of consciousness, and pertinent findings that we're seeing, a set of vital signs, things that we've done. We have oxygen on them, et cetera, et cetera. So just updating them on what we've done so far. All right, the mnemonic for remembering the level of consciousness. We're getting to this one, but the one we're talking about here is AVPU. Alert, voice, or verbal, pain, unresponsive is what we're looking for. A patient who responds only to a pinch in the muscle near the neck is said to be responsive to, that would be pain, because we're pinching their muscle in their neck and they're responding to that. The next level down would be unresponsive if they don't respond to that. Okay. Stop share. I do want to show you why these sheets that I gave you are important. So this sheet is, chapter 9, PPE, scene safe, mechanism of injury, additional EMS, and then we add in consider C-spine right here. Primary survey, this is our chapter 10 right here. So determining responsive level of consciousness, this is our AVPU, alert, voice, pain, unresponsive. Determine their chief complaint, that's what the patient's telling you. Whatever their chief complaint is, whatever they're saying, my chest hurts, or it hurts here, I don't know, I don't feel well, that's your chief complaints. Apparent life threats under this right here would be if somebody's bleeding out, like there's blood everywhere, you can see it squirting out of their artery, you got to get a tourniquet on that. That comes before ABCs. If you don't see anything like that, that's an apparent life threat, we move on to airway breathing, doing our assessment, assuring adequate ventilation, rate, and depth, and initiating oxygen if we need to. Then we move to circulation, which is controlling any major bleeding that you see that might not be this life-threatening bleeding, assessing their skin color, temp condition, checking their pulse, rate, and quality, and then identifying a treatment decision, like transport decision. So do we need to start packaging them up and getting ready to go or not? Can we stay and play around a little bit? The next chapters that we're getting into are history taking, secondary assessment, vital signs, and then doing a reassessment. So this is patient assessment medical. When you go to trauma, it's very similar. So this one is PPE. These are all the exact same until you hit airway. So PPE, the scene is safe, making sure the scene situation is safe. What is our mechanism of injury, usually for trauma? Do we need additional people? ALS, helicopter, fire, we need people out there. We need to consider C-spine stabilization. This is our AVPU. I don't know why I don't write AVPU here, but this is our AVPU, determining a level of responsiveness or consciousness. This is AVPU. Chief complaint, apparent life threat, same thing all the way down. The only difference on this one at the top here is this is going to break airway, breathing, and circulation down into 3 different categories, where medical has airway and breathing together and circulation. Trauma, we're dealing with, do they have an open airway? If it's not open, we open it for them. And if we need to insert an adjunct. So this would be our oral airway or our nasal airway, this adjunct. Checking their breathing, assessing their breathing, rate, quality, making sure they have adequate ventilation. So our rate 10 to 20 or 12 to 20, getting good chest rise. Do we need to initiate oxygen therapy? And then here is we want to manage any injuries which may compromise breathing ventilation because this is a trauma. So they might have some broken ribs, they might have a pneumothorax, they might have some stuff going on in their chest that might affect their breathing. So we need to look for that. Circulation, check their pulse, rate and quality. We're going to assess their skin, color, temp, condition. We're controlling any major bleeding, which is the same. The one additional to this is we want to initiate shock management. So initiating shock management is if they are appearing to be in shock, we want to make sure that we are laying them down supine. We have high flow oxygen on them. We're covering with a blanket, and we're trying to get them out there and packaged immediately, and doing that immediate transport. So when it comes to identifying patient priority and treatment transport decisions, this trauma is going to be based on what's called the Glasgow Coma Scale, which we'll get to when we talk about some of the trauma chapters. And then we'll start working our way through history, secondary assessments, and reassessments in this as well, moving along with vitals in the next chapters coming up. Those make sense a little bit more with the chapters that we did? Or am I like, that's a lot of information? Okay, I'll keep bringing those sheets up as we go through these chapters. You guys can keep watching this over and over on the YouTube thing. I'll make sure that's on there either tonight or tomorrow. But it's not a bad idea to print those sheets off. It's a good way to start like doing your patient assessment for these situations. And I have some other sheets I'll be giving to you along the way as well. But it's a good way to start off with patient assessment, is learning how to just do a systematic approach to the patient care and assessment. So, all right, questions. That was a lot of talking, but we're done. So see what the chat is. Okay. So far, so good, it looks like. All right. If you do have questions, feel free to email me. Tomorrow morning, you guys should be getting another email for the next set of chapters, which is 11, 12, and 13. So finishing up history and vital signs, secondary assessment, and then we'll talk about communication and documentation. So I'm actually going to stop recording. So